Well, welcome everybody. My name is Ed Lebo, and I'm the Executive Director of the American Anthropological Association, and it's my great privilege to welcome you to this afternoon's forum on anthropology and collaborating with our colleagues around the world to intervene in the Ebola outbreak. Before we go much further, though, I'd like us all to pause and rise and have just a moment of silence in honor of the nearly 5,000 people who have lost their lives in this outbreak. Okay, thank you for that. So this is a remarkable occasion, I think, certainly in the history of the American Anthropological Association. This is an effort that has come together rather rapidly. We've just spent a remarkably productive day and a half with a group of about 25 anthropologists and allied social scientists talking about ways in which we can contribute our expertise and knowledge in immediate ways and also with our eye out to the longer term horizon as we think about opportunities for contributing to health promotion and disease prevention, to evidence-based monitoring and evaluation of interventions that are underway or planned, and also in longer-term systems strengthening. This moment would not have been possible without the generous support of a few key sponsors, and I'd like to acknowledge the Wenner-Gren Foundation for Anthropological Research, the Harry F. Guggenheim Foundation, the International Development Research Center, and 3 different institutes of the George Washington University. There is the Humanitarian Studies program at the Elliott School for International Affairs, the Institute for Ethnographic Research, and the Institute for Global and International Studies, all of whom have contributed materially to the possibility of bringing this growing network of committed anthropologists and social scientists together. I just want to tell you in a few words about the association itself that I represent. We have about 10,000 members. We're divided into 40 different sections, and if you add up the total membership of the Society for Medical Anthropology, the National Association for the Practice of Anthropology, the Society for the Association Anthropology of Food and Nutrition, and the Association of Africanist Anthropologists. That's just 5 of the sections in our association. They account for fully 1/4 of all the members of the association. So the expertise that's represented among our association that can contribute to interventions in global health crises like the one that faces us today in the Ebola-affected regions of Western Africa is really pretty significant. And our ability to pull together some of that expertise to begin a conversation and planning for ongoing activities is really critical to that. There have been 4 people in particular who've been instrumental in organizing this, and I'd like to recognize them by name. Sharon Abramowitz from the University of Florida, who has really been a driving force here. Danny Hoffman from the University of Washington, Mary Moran from Colgate University, and Susan Shepler from here in Washington at American University have constituted a steering committee along with a little nudge and help from myself. And so I want to thank you publicly. I'm sorry, and Steve, of course, who I was saving to last because he is indeed our host, Steve Lubkeman from George Washington University. And so before I make any more mistakes, I think I will stop, and I would like to introduce to you one of the sponsors of this organization, who is also local host from the Institute for Global and International Studies, and that is anthropologist Barbara Miller.
Yeah, so hi, I'm Barbara Miller. You may wonder why we have to say we're the Institute for Global and International Studies. Just we got you covered. It was founded by political scientists. And if you know them, they have this little thing about who does global and who does international. But now it's headed by an anthropologist. It's a multidisciplinary group of faculty, students, and staff. We work on topics including human rights, migration, health, gender, the role of culture in society, and change, and connections to policy. We definitely seek to engage the professional and policy community. We do it through events like this, and we here, luckily situated in Foggy Bottom, get a lot of people to come and listen to us, and we think and hope, we have no monitoring and evaluation, that we are creating change and getting anthropology and grounded on the ground. Haven't anthropologists been on the ground forever? We are on the ground. We can inform the Washington so-called community. IGES also houses the Africa Working Group, which I founded a few years ago because I thought GW was derelict in not looking at contemporary African issues. Some 30 faculty across the university, including Steve. We should mention Steve more often, right? Yeah. Looking at African policy issues as informed by social science knowledge. Several years ago, I also started the Culture and Global Affairs program. This is my baby, and my dean supports it. He says, I kind of like Culture and Global Affairs program. Is that about orchestras going to Korea? No, although I like that. It's really about social science knowledge informing policy here and abroad. I also direct the Medical Anthropology MA concentration at GW, which is so far very small, so if you have any students who want to come to it, tell them to talk to me. I am keenly interested, and I'm not going to stay up here much longer because I want to hear what you all have to say about the findings from the group of experts who have been thinking long and hard for 2 days. I want to hear about how we can document that it's critical to include knowledge of society and culture to address a health problem, because a health problem is never just a health problem, looking for a medical solution. Health and culture go hand in hand. Cultural anthropologists and others who have deep knowledge of societies, including small villages, urban neighborhoods, and the cultures of institutions such as NGOs, governments, clinics, and more, must have an equal place at the table where decisions are made about how to prevent and solve health crises. Often, anthropologists' knowledge sits with us. We talk to each other. We all know that. We have to do that. We won't get tenure if we don't. But it's so exciting that this event was brought together so quickly and with such a stellar array of experts. Applause, again, to all the organizers. Cultural anthropology has been called a slow science. We have to be a slow science. That's how you really know what's going on the ground. But maybe we can have a fast side where we can change to some extent. And this event, I think, is one example that some anthropologists cannot be only slow scientists, but we can also be fast engagers and be more nimble and more quickly engage with and respond to urgent public events. This is awesome. Thank you for being here.
Thank you, Barbara. Next, I'd like to ask Sharon to come up here and share with you a bit about the goals and objectives for this initial mobilization of the network and for this afternoon.
Hello, everyone. I want to thank you for coming, but I also want to warn you a little bit that the people that are about to speak today on topics of such importance happen to have extraordinary levels of expertise, but have been asked to put their presentations together on the basis of extremely rapidly engaged and extremely intensive workshop events that have literally transpired within the last few hours. So I ask you for your generosity as well as your engaged interest. I've been asked to talk a little bit today about this network that we're putting together. This network that we have put together not just in the United States, but also with colleagues now in France, in the United States, in Guinea, Belgium, the Netherlands, the UK, Canada, Germany, Senegal, Liberia, and Sierra Leone. We've been working incredibly rapidly to raise the profile of anthropological knowledge in the context of this Ebola response. I would like to thank the often unacknowledged facilitators that have made this event possible, specifically email, Skype, and Google. Because it's actually really hard to imagine how an event like this could have transpired without internet technologies, right? I have just met within the last 2 days people who I've been speaking to for the last 40 days. Now, let me tell you a little bit about how this event transpired. About 40 days ago, I contacted the executive board of the American Anthropological Association after attending a different Ebola event here in Washington, D.C., over at Georgetown. And I did not write a very nice email, but I basically said, why isn't the American Anthropological Association doing anything about Ebola? To which Ed very gently replied, we're having a webinar tomorrow, so perhaps you want to tune in. Duly noted, efforts were being made on the ground. And at the same time, I was talking off the record with a bunch of my colleagues about the issues of Ebola, and people were concerned and they were upset, and we were all seeing similar mistakes happening. We were watching the rising mortality curve, and we just felt like we couldn't do anything to stop it. And that was a hard place to be in. So after speaking with Ed, I approached the Wenner-Gren Foundation, and I said, anthropology needs to take a stance with regard to Ebola. And Leslie Aiello, the director of the Wenner-Gren Foundation, said, send me some thoughts. And so what I proposed was that essentially we, with the American Anthropological Association, very rapidly pull together the finest minds, especially in the United States, but also internationally, who have been working in the regions of Guinea, Liberia, and Sierra Leone for the last decade, 2 decades, 3 decades. And I'll share with you the same information that I've shared with other members of this audience. I did a backhand calculus, and I realized that in the workshop, which was attended by approximately 30 senior level anthropologists in these regions, and also people who are experts on infectious disease, we had accumulated something close to about 300 life years of ethnographic research experience in these 3 countries in the last 35 years, right? It's an enormous repository of information and knowledge, right? And oftentimes our approach is to go slow, right? To do our ethnographic work, to be there, to be able to report on what's going on locally, right? But with a body of information and experience and a deep well of social networks that continues to be very active on the ground with populations that are still being affected, friends, family, research assistants, research collaborators, we have a sense of what's going on, and I thought that if we all came together, we could make some fairly concise, focused, and directed recommendations for how to improve the overall response. But there were challenges in organizing this, and probably one of the biggest challenges in organizing this is that we've had to work really hard to overcome a certain degree of isolation from the policy and global health communities. While the work of anthropology is universally regarded as being extremely important and extremely relevant for global health crises, it has been a struggle for us as a field to understand how we could bring together all of our resources together as a community in order to inform a response. So we began the careful work of starting to reach out to people who are involved in the field, people who are involved in the government, and people who are involved in international policy. And we've been reaching out to them, and we've been making ourselves available as a resource, as an open resource that is willing to share information pretty much on almost any terms in order to better inform local activities and local efforts on the ground. And I'm happy to say that offer has been embraced by certain key partners. We have a very close working relationship with the UN mission for the Ebola emergency response. We're collaborating with the World Health Organization. We're collaborating with the World Bank. We, as part of our network, we have anthropologists who are based in many of the organizations that are operating on the ground, including MSF. For the purpose of this workshop, we decided to identify 8 key topics for the purpose of making anthropologically informed recommendations and issuing guidances based on conditions that we know to be happening on the ground. And I'll just inform you, although you have this list in front of you, of the 8 key topics that we identified as being real priority areas for attention. These include care of the sick, health communications and community engagement, health and state system strengthening, risk factors, including issues of mobility, food security, youth, gender, attending the dead. As you all know, funerary practices are an important factor in this Ebola epidemic. Identification, diagnosis, and surveillance of cases. Militarization, military coordination and security issues. As some of you know, the U.S. military involvement in Liberia is, I believe, the first time that we've ever used the U.S. military to engage in a global health response. And these, the countries that we're talking about have distinct histories of conflict and post-conflict reconstruction. And finally, beyond the epicenter, how the international community is responding to the presence of Ebola and to the rise of this epidemic in these 3 countries. And that includes preparedness and precautions that are being taken in neighboring countries, as well as other kinds of responses like those that we're observing in our own. So, I do, really? Okay. I will share with you broadly speaking, although I'm probably going to cede 1 or 2 minutes, just a couple of, like, an overarching sense of what our key recommendations are, and I'm sure that my colleagues are going to fill this in for you beautifully. We believe, as a community of anthropologists who are experts in this region, that until there is a vaccine, community engagement and community mobilization is the fastest and the least expensive way of effectively resolving this epidemic. We believe that the local context in the 3 most affected countries is unbelievably nuanced, but it's not unknown. It is totally knowable, and it is totally accessible. Okay? These regions and these peoples need to be engaged with the social structures, social institutions, and social facts that are present on the ground right now. And if we do so, global health interventions can be hugely successful. We understand that communities are already mobilizing local resources, including family support and caretaking roles, rural-urban networks, gender roles, and other local institutions in order to address this response. Okay? The global Ebola response needs to work with these institutions rather than against them or in ignorance of them in order to have maximal impacts quickly. That being said, we shouldn't be afraid of large-scale interventions. We support the creation of information and reporting systems that are centralized to facilitate rapid epidemiological analysis and response. And we see this potentially as a systems of strengthening, but they also must be implemented carefully so that they are not a source of abuse. We think that the communications channels that need to be implemented are not one-way communications channels from the people who are delivering interventions to local communities. communications channels need to be two-way. There needs to be a rapid way for communities to report on what it is that they're dealing with and what it is that they're managing so that they can receive support for their real problems in real time from the international response. I'm going to leave it to my colleagues to inform this further, but I will also say that there was a very strong level of concern about and awareness of the fact that that the local situation is changing rapidly. As one of my colleagues said, every week is like a year in this epidemic, and you just don't know what is going to come. The science is moving quickly, the epidemiology is moving quickly, the social conditions are moving quickly, and even the climactic conditions are about to have a meaningful impact upon this epidemic. Okay. So what we should be paying attention to is the mobilization of the largest and best network that we have available on the ground. The people that we know, the local communities, the people that we have deep social ties to, so that we can get information out and implement the best possible response that we can.
Thank you, Sharon.
I'm Susan Shepler from American University, and I'm going to be chairing, but that mostly means being timekeeper. I'd like to call up our first four panelists. You know who you are. Come to the front so people can see you. I won't take much time with introducing people, since you have a little bit of information about each of the speakers in your agenda. So first of all, I'd like to introduce Vinh Kim Nguyen from the University of Amsterdam, who's going to be reporting back on our group work on care of the sick.
Thank you, Susan, Sharon, and Ed for having me here. And I wanted to thank the members of our group. We had very interesting discussion. And before going to the 6 major points that came out of that discussion, I think it's worth reminding us that there's actually remarkably little clinical knowledge about this virus and about treatments, the best way to treat it. As you know, it's been limited to constrained outbreaks, and this model that's developed of treating people in isolation units is not necessarily one that's well documented or supported. We tend to think about medical knowledge as being certain knowledge and the other knowledge being a bit fuzzy, but in this case there's a lot of unknowns on the medical side. So we don't know the best supportive treatment. We obviously don't have a vaccine, we don't have any specific drugs, and we don't even know the best way to prevent infections in terms of infection controls in healthcare settings. And we also are not completely sure about the best way to triage potential patients. So that being said, we have a model, as I mentioned, that was developed in Central Africa and that was scaled up by Médecins Sans Frontières, which involves Ebola treatment units, or ETUs, and this is what's being scaled up currently. And there's a kind of inertia to that model. It took a while to get started, and now it's scaling up rapidly. But the epidemic itself is changing very rapidly. So most of you will have heard that the latest figures from Liberia and possibly in Guinea, certainly Conakry, suggest a drop, thankfully, of incidence. So it seems quite real that there are less new cases in certain areas, but we don't know why. We don't know why that's happening. So within that context, when we talk about care and support, our first key recommendation is that we need to draw aggressively on ongoing innovations occurring in the field, both by being developed both by NGOs and actual community members, to supplement and diversify the care models that we have, which has, as I've said, just been until now limited to Ebola treatment units. So we heard about community care centers being developed by Save the Children, by various other initiatives for home care kits being distributed. So the basic bottom line here is that we know very little about where this epidemic is going and why, and we know very little about the best way to treat it. So we need to learn quickly from what people are actually doing. The second point, which is linked to this, is that we still don't understand. We don't know how to best count the epidemic. There's a lot of uncertainty around the numbers and the fluctuations in incidence, and we need quite urgently research to better contextualize what's going on there. I realize I'm probably going too fast because I'm going to be over in a few minutes, but I think that will leave us time for discussion. But when it comes to numbers, once again, as you know, we know we're undercounting and underestimating, but we don't know by how much, and that has an important impact on the mathematical models. And ethnographic research can be very helpful, as Sharon has pointed out in some of her writing, in counting the dead and in understanding the underlying shifts in practices that are contributing to decreasing or increasing incidence. And here, again, I think it's worth stressing that there's been incredibly rapid change. People are adopting new practices very, very quickly, and and this has been made clear in much of the media reporting. Third element that I'll spend a little bit more time on is that, of course, there's been an unprecedented response in terms of research and clinical trials. As many of you know, there are basically three important avenues of biomedical research: vaccines, obviously, with much debate, and thankfully this virus is not as complicated as HIV to develop a vaccine, so it's quite realistic to think that we'll have a vaccine within a few years. But there's quite a lot of debate currently on who to vaccinate first. Do we vaccinate healthcare workers, and so on and so forth. There's secondly, a second avenue of research is into drugs, and there's a number of drugs, experimental drugs, two actually, possibly three, TKM, favipiravir, and brincidofovir, that are currently being rushed into clinical trials. And I'd like to underline that some of these clinical trials are being conducted before the usual preliminary steps of testing in primates and in healthy volunteers. We're jumping straight to using these drugs in patients. So this is also unprecedented historically. And the third avenue of research is, which is happening right now, is the use of convalescent plasma. So this is the idea of transfusing plasma from people who've recovered and essentially transferring their antibodies into the bodies of people who are sick. So there's a kind of a scramble for Africa going on here, where all these research teams have descended on these three countries and are trying to implement these trials, find research sites, and so on. And this is in the context of a place where, a part of the world where medical research has a problematic and checkered history. So, for example, in the area where this epidemic took hold, which is at the border between Guinea, Sierra Leone, and Liberia, this was the foyer. I don't know the word in English. Was a breeding ground or whatever for sleeping sickness epidemics at the beginning of the 20th century. And these epidemics were controlled using Pasteurian campaigns where mobile teams went from village to village, rounded up people. If they had lymph nodes, would biopsy them or do lumbar punctures, and then put them into camps and treat them. So these were fairly coercive campaigns with painful, and the treatments were arsenic injections, which were not pleasant, apparently. So there's a kind of a history there which forms a historically rational basis to suspicion about these outside interventions. So we clearly need to be very mindful of this history when it comes to the implementation of these trials. And this is independently of debates about the ethics. I think that's not something we need to get into here. But the idea of saying this is all about, you know, atavistic, cultural witchcraft beliefs and so on, I think is to not do justice to the historical rationality behind these perceptions. And we are dealing with, particularly when it comes to giving drugs to people who are dying or transfusing the blood of survivors into people who are sick, we're dealing with practices that are symbolically quite charged. And this is independently of the fact that we have, you know, these people in spacesuits walking around, which just kind of saturates the perception of this disease. So yes to research, but we really need to be very careful. Not so much, well, I mean, because it's important for these, it's crucial to this research being implemented and to finding interventions, but there will be a legacy, a historical legacy that we need to be mindful of. And sort of three final points to wrap up. The importance of survivorship, and I think this will come back in other discussions, that we don't know yet enough about survivors, and they are key to the response, not only because they are immune, but because they can function as ambassadors, and also because many suffer stigma, and many probably want nothing more to do with this disease. We need to better support caregivers, whether it's home caregivers or people working in treatment units. And we need to develop interventions that are not only aimed at individual support, but structural interventions to decrease stigma and to help integrate survivors. And the final thing is, I think we're looking at, when we talk about care and the sick, at an invisible, well, one will come visible soon, epidemic of mortality from non-Ebola causes. So we need to move the response beyond a disease-specific model to one that focuses on rebuilding health systems. Thank you.
So just a reminder, we'll have all 4 presentations, and then there'll be time for questions and answer at the end. So next up is Doug Henry from the University of North Texas, speaking about health communications and community engagement.
Thanks. Thanks, everybody, for having us. In considering this topic of communication, the first thing that we realized as our breakout group was that anthropologists tend to think of communication slightly differently than what tends to get applied on the ground. For us, communication is really about engagement, as in we communicate with, or it's necessary to communicate with, not communicate to. So in a situation like Ebola, where you have this very terrifying event, international system of humanitarian relief kicks in eventually, and implements this very top-down approach. And one of their first priorities is, let's get the message out. Right, Ebola kills, be afraid, don't touch dead bodies, call us. And predictably, this is what happened in this particular outbreak, at least up until August of this year. The logic seems to have been, let's push our messaging out through as many channels as possible. And you can actually watch news clips of this online. Street-level educators in Kailan, where I work, and saying, you know, if Ebola gets into your family, they will die. Call us. So we realized as a group, so as anthropologists, we realized that that culturally, this is really a terrifying message. And so if the point is to be taken seriously, yes, point accomplished, right? That's very effective. And yet most of us have either worked in this area or worked in other epidemics long enough to realize that this kind of fear messaging, while it does get people to take a problem very seriously, it's also associated with a lot of very maladaptive kinds of behaviors. Namely, it increases stigma about a disease and then drives it underground, right? becomes hidden and not talked about. So you've actually stifled real communication that's occurring in the community. So our recommendations are, well, one, obviously, we can put the brakes on the fear messaging, or at least fear messaging is really only appropriate if it's accompanied with a healthy amount of culturally appropriate self-efficacy. So what is it that pushes people in these countries to act responsibly, to feel confident in their own abilities? We realized, well, for one, it's to exhortations to protect families, and that one can actually be a responsible family and community member. Our largest recommendation is really about communication itself, and that is that it needs to be much greater than about just messaging. Again, more about community partnerships, communicating with, as opposed to communicating to someone. So thinking about communication as collaboration, we realize it really occurs on all these different levels. At the very grassroots level, it can be collaboration surrounding messages that can locate things like culturally appropriate messages, culturally appropriate symbols. Maybe more importantly, identifying and engaging with different groups of people that connects the managers of an epidemic response to those who are trusted members of responsive social networks. They can be remarkably effective at identifying local concerns. Again, remember you're communicating with them, not communicating to. And then addressing their concerns, crafting messages that address these concerns. So in this geographical area, the particular groups that one would work with are incredibly diverse, but also very easily identifiable. They're the people that we work with. So soap makers, traditional healers, religious leaders, society leaders, market women, taxi drivers unions, students, and even those in the diaspora who are located around the world but then go back to these countries to visit families. We think it would be really nice to start thinking of them as potential points of contact and intervention and engagement rather than, say, risk groups. So to reiterate, communication with reveals how to identify relevant groups, how to discover relevant messages, how to frame them appropriately. Filters down ideas, filters up questions. So this perspective is really all about engagement. Letting people ask questions, respecting their expertise, keeping in mind that they are colleagues. They are not tools to implement messages. They are people to engage with. One more point at this level. Sorry, two more. Communication with needs to be a continuous process. As someone in our group pointed out, the epidemic is evolving quickly. Behavioral responses are evolving quickly. Knowledge is evolving quickly. So this is an iterative process that needs to be continuous. And finally, at this level, collaborations at the grassroots level allow you to recognize this flexibility that can be built into cultural systems. So for example, by now we think almost everyone in Sierra Leone, Guinea, and Liberia has heard this message: don't touch dead people. When you go to a funeral, don't touch the dead, particularly if Ebola is suspected. Mary Moran will talk about this later, but at the communication level, we realize that more important than just preaching this message and pushing it out through all these different channels, don't touch the dead, don't touch the dead. Engagement allows you to identify points of flexibility within cultural systems that are there. I mean, there is lots of flexibility to this kind of system. So flexibility that allows families to accomplish the same amount of respect and sense of a proper burial as touching wood, but just a different, without the actual touching. So at the middle level, I need to keep an eye on my time, in this outbreak is the communication that happens sort of at this middle level between public health agencies, district level people, and the local communities. And here, communication, what we've seen, really indicates the need for collaboration and trust building. One of the problems that we've seen and identified is that there has been this very militaristic use of imagery. And Danny Hoffman will talk about this later. But, you know, fight Ebola, let's fight Ebola. While this imagery has really good things associated with it, like mobilizing resources, wartime imagery can also be really problematic in how epidemics become responded to. So for example, near the area where I work in Sierra Leone, just 2 weeks ago in Koidu town, there was a small public resistance when a body went to become collected. So youth sort of rebelled against this burial team. What this really revealed was a lack of trust. Soldiers, perhaps unfortunately, had accompanied the burial team, and when this public response happened, soldiers opened fire and 2 bystanders got caught in a ceasefire and died. So we realized that there are other engagement and collaboration reveals other kinds of imagery that can be incredibly important and equally important or equally relevant. So for example, perhaps team-based sports imagery, soccer imagery. Why does one need to have a militaristic approach to this, right? Why not work towards a goal rather than fight, 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 right? One implies more collectivity, right, and cooperation. The final level, if I have time, Susan? Excellent. The final level is really one of interagency communication. By this, we mean improved communication not just between agencies and their clients, but between agencies themselves. In our own experience, we've all worked as consultants, as employees, advisors. Interagency communication is often guarded, competitive, proprietary, sometimes territorial. Part of this is the structure and institutional culture that humanitarian agencies are in. They compete with each other over clients, geography, funding. Self-image management is very important to someone who needs donations. But part of this is something we realize is just hard. Collaborative communication is difficult. We realize that even within our own discipline. At the beginning of this, it was incredibly difficult to keep track of who was doing what, when, and where, particularly in real time. And yet, as we've shown in this group, we want to be a model for this. Because as we've shown in this group, you know, it's brought us together from Senegal, Sierra Leone, Guinea, Belgium, Liberia, the UK, Canada. Global responses of our discipline, and the global responses of our discipline. You know, with today's technology, the technology of websites, listservs, Google groups, global Skype meetings that can connect people, this technology, coupled with a lot of willingness and willpower, makes this kind of collaborative communication possible and increasingly needed. Thanks.
Next up, we have Adia Benton from Brown University, who will talk about health and state system strengthening.
Thank you. So I'm obviously not live tweeting this part, but I have been live tweeting. So hopefully you'll catch up on what's going on. I'm talking about health systems and state strengthening, which, as you can imagine, anthropologists have fewer very concrete recommendations, but many suggestions and questions and concerns that we'd like to address. And so, as most of you know who are interested in this response, we've noticed that weak health systems are part of what has precipitated this crisis, or at least is part of why this crisis has been so difficult to get under control. It's also been one of the things to fail under the duress of this Ebola crisis. Many people have noted that other conditions that are not Ebola are going untreated. Surgeons that I work with in the area have been very concerned about performing C-sections and other basic surgeries because of their fear of contracting Ebola or passing it along to others. And so one thing that we were trying to understand was what factors have led to these conditions of weak health systems. Many of you who study public health understand that this is a long process. So while the war is very important in this, or the wars in the regions that were the most affected are a part of this, there's also a legacy of structural adjustment in which social services like education and health care were very much gutted under neoliberal policies in the 80s. In fact, might have even spurred some of these wars or been a contributing factor. There's also donor priorities that have also shifted over time from something like primary care to disease-specific modalities, and we've discussed this earlier. So within this in this framing context, we were interested in what is it that anthropologists can contribute. Some of us study institutions and networks, which is what you've been hearing in the communication sections, what you heard when Kim talked and Doug talked. We are interested in the coordination between the states and international responses. So far, it looks like there's an awful lot of top-down response. So we're talking about ideas emanating from international institutions and ones that move across borders, but could be more responsive in the other direction. What kind of community responses have we seen that have helped to deal with treatment of cases, the identification of cases, the isolation and containment of cases? So this is something that I think is really interesting and important. The other piece is the health workforce issue. Many of our interlocutors who live and work in Sierra Leone and Liberia and Guinea have talked about some of their trained doctors and nurses who actually who are unemployed. How can we get those people compensated, paid, and into a system to help to care for people who are sick? How do we understand the deployment of other kinds of health workers to address the other health problems that certainly must exist during this Ebola crisis? The third point that I'm hoping that we can also talk about, especially in the Q&A, is health systems data. And we have been having a long discussion about the lack of openness about the data being collected in health facilities and the use of and that trickling upward to WHO and its collaborating institutions, but have not been accessible and responsive, accessible to people who want to develop models, predictive models, for people who want to understand how to better allocate resources within the existing and very weakened and fragmented health systems that currently exist in the crisis. I feel like I should step back and actually say the bigger issue, which is what is a health system to begin with. We know that we're talking about health institutions like health facilities, dispensaries at the local levels. We know that we're talking about systems, stuff, supplies, equipment, all of these things. These are things that are constantly in shortage, and systems for making sure that those supply chains are consistent and good have been a problem. I talked about the health workforce. That in addition to people being trained and not having employment, there are lots of people who aren't being trained. There's not nearly enough investment in people who do healthcare work. We in our group also talked about Guinea's African socialist system, in which every local dispensary had a community health worker who actually did active surveillance. That was dismantled in 1984 with Sekou Touré's death. And these kinds of models have existed and worked very well. They've also integrated traditional healers and local health workers as well. I mentioned this to suggest that there are alternative ways to imagine a health system or to reimagine a health system, and some of those lessons come from earlier iterations of health system strengthening under African socialism. I'm using that as my example, but certainly there are other models. But the important part of that model is the potential for bottom-up rather than top-down, or a combination of bottom-up and top-down approaches that can better strengthen the Ebola response in the current crisis, but also be stronger for the future. And this is one of I think the constant debates that we've had. Are we talking simply about Ebola? Or are we talking about health systems well beyond this? Is this an opportunity to move this thing forward and to really have a serious conversation about health systems? People have been talking about health systems for at least 15 or 20 years. Well, and 50 or 60 years, actually. But the most recent debate has been about primary health care, vertical systems that look at HIV, malaria, TB, and all of these things, diagonal approaches, and moving beyond those. And so this question for everyone is, how does one imagine a health system that is strong and that is responsive to needs into the future and beyond this crisis? The last thing I wanted to bring up, and it comes out of other discussions about what a health system is what a basic public health looks like. What is a minimalist? I was told I can't talk about Foucault, but I'm gonna. What is a minimalist biopolitics? I know, ixnay on the I can't do pig Latin and French. Anyway, the point being, a minimalist biopolitics. How does governance happen with health systems? You have to have basic systems in place. We talked at length about identification cards. Populations can't be regulated, measured, counted, and taken care of unless they are in some ways also documented. And it can't just be about counting, measuring people, but doing so in a way that actually confers a benefit to them. Does that make sense, what I'm saying? So we went back and forth on the ID system for a range of reasons that are related to the histories of various kinds of interventions in the region and mistrust and suspicion about certain kinds of official responses to all kinds of things, including epidemics and outbreaks. So to rehash this piece again, I think part of health systems requires this biopolitical spirit, right? Regulating, managing, and controlling populations by actually counting them and documenting their existence. Births and deaths. My demographer friends are very much about registering births and deaths. Again, this is subject to debate for those of you who understand the region and understand the history of counting. So I'll end there with the expectation that we'll have a longer, deeper conversation.
And I'm pretty sure we'll have the anti-Foucault argument in the next panel, if I'm not mistaken. Finally, we have Mike McGovern from University of Michigan talking about a range of risk factors we identified: mobility, food security, youth, gender, maybe others.
Thanks, Susan, and thanks to the organizers for all the work you put in to make this thing happen. I'm going to talk about four things, the four that Susan just noted. And I want to start with a question for all of you in the audience who are not West Africa specialists. How many of you have heard about the link between bushmeat and Ebola? Pretty much everybody, right? How many of you know when the harvest is for rain-fed rice production in West Africa, who are not West Africa specialists? No hands, right? Well, it's right now. And that's critically important because it's one of the key labor bottleneck points in the agricultural cycle. And what happens if you cannot get together 40 or 60 people to go out to your rice field, which might be a 2-hour walk from the village, and all spend an entire day, sometimes 2 consecutive days, cutting the rice, bringing it together, piling it up? What happens is that birds and rodents and other animals get all of the rice, right? Or they'll get a large proportion of it. In the context of Ebola peaking in these 3 countries, all of which are rice-growing countries and where rice is the main staple food, what we're going to be getting is a series of kind of half and quarter harvests for most of the rice cultivators. This is going to have an effect on people's nutrition for the entire coming year. Moreover, the next labor bottleneck is going to be the period when people are clearing the fields for next year, cutting down trees and brush, burning it, gathering together the parts that didn't burn, reburning them, right? This is going to start in January and continue on until about April. If Ebola has not been reined in by the end of that period, then the fields that are going to be planted for next year's harvest are also going to be compromised. So our group's first recommendation is that the international community, the Food and Agriculture Organization, FAO, of the United Nations and the World Food Program need to be planning for 2 years of major food support to this entire region. Okay, this is a key finding, and moreover, people save 10% of their harvests to plant the next year, right? You don't go to the ag store in the center of town to buy your seeds in West Africa. You actually save some of the seeds that you harvested last year to plant for the next year. And so that has to be factored in. Otherwise, what often happens and happened during the period of the wars in this region is that people eat their seed stock, right? Because they're hungry, they don't have enough to eat, they eat their seed stock, and so it completely sabotages the possibility of feeding themselves the next year. And I'll just add as a footnote to this that epidemiological research has shown that people's nutritional status before they get sick has a clear effect on their how well they do when they get hit with a catastrophic illness like Ebola. I don't know, I was talking with some of my specialist friends like Adia. I don't think there's any actual research on this in terms of Ebola, but the research is quite solid, I think, across the board for other diseases. So people's nutritional status is actually germane to how well they do in surviving the disease. Second subject that we talked a lot about was mobility. There haven't been any cases of Ebola in Côte d'Ivoire, despite the fact that Liberia, its neighbor to the west, has been the hardest hit of any of the three main countries. Why is this? Well, we don't actually know. But I can tell you this. Starting this month and next month, when that rice harvest is finished, when the dry season has set in, when the roads that have been impassable from July until October begin to dry up, there are going to be a lot of Liberians going to Côte d'Ivoire. This has been the way that it's worked for decades and decades. Young men in particular will start moving after the harvest in order to do artisanal diamond mining. Many of you have heard about that in the context of the Sierra Leone Civil War. Artisanal gold mining, cutting timber in the deep forests, and also looking for wage labor opportunities in places like the Ivoirian cocoa plantations and in big cities like Abidjan and Dakar and Bamako and Conakry. Places where they can make money to bring home to help feed their families who are running out of food, right, because of the reasons I already explained, or to get together the money that'll allow them to get married in the coming year. So that kind of mobility is a real epidemiological worry and threat. If people are already sick, they could be moving. But we really need to disaggregate people who are moving for these economic reasons in a way that people have been doing for generations, and people who might be moving, for instance, because they know they have Ebola and they're seeking better care. Now, what we think and whatever policies come out of our discussions, in some sense, are neither here nor there, because communities themselves, we are hearing all the time from all of our networks in the region, are already taking matters into their own hands. There's a lot of people, communities, villages, even the parts of cities, different areas in cities, where people are setting up roadblocks and checkpoints, monitoring and controlling the flow of people and things in and out of their communities. When somebody who is unknown to a village just shows up, they are subject to the same kind of surveillance and worry that people showing up in our airports with Liberian and Sierra Leonean and Guinean passports are subject to, and for largely the same reasons. So people are already doing this, and they've done it in the context of the civil wars in the region. So this is a kind of a set of practices which is already quite well developed, and people are reactivating them in the context of Ebola. Now, this can be a good and a bad thing, and our key suggestion on this issue is that international actors should acknowledge and indeed validate the efforts of communities to monitor and control flows of people and things in and out of their communities, but that there are real risks attached to this too. There's a risk of scapegoating, right, of strangers or of anybody who presents the unknown. We see this in the United States, right, and other Western countries who tend to project all their fears onto West Africans. But this can happen also in a village to village, or, you know, if a Nigerian shows up in a Liberian village, or, you know, a Guinean shows up in a Sierra Leonean village as well, right? And so our suggestion is that by beginning by validating and accepting these practices, then the state can begin, and the international actors can begin a conversation which would have to do with asking people, what is it that you're worried about? What is it that you're most ardently trying to control? And can we have somebody like a police officer or somebody from the health services be a participant in this process, so as to perhaps blunt some of the potential you know, overreactions that could come out of this. And one of our members came up with a very pithy statement, which I think sort of covers in umbrella terms our recommendations as a whole, which is to meet people where they are. Meet them where they are physically, emotionally, intellectually, right? And as Doug has already said, make this a conversation rather than a one-way transmission of information. I'm going to talk very quickly about youth. There are a lot of Ebola orphans, right? And they have tended to be both stigmatized and left, in some cases, to their own devices. But by the same token, there are a lot of institutions already in play in the region, including the institution of fosterage and adoption. And so our recommendation there was to reactivate some of the institutions that existed during the civil wars in the region, like family tracing, which was used by the Red Cross in the context of refugee families to find extended family members who could take kids in. But in doing that, as one of our contacts said, people in villages are saying, we can take in 2 or 3 kids, we can't take in 12, right? So there has to be some provision also for supporting the families that are doing this, this fosterage and adoptive care. And I'll stop there.
Thanks to our 4 representatives of our groups. It was very difficult to, I'm sure, to distill this down into something that could be done in 10 minutes. I'd now like to open this up for questions and comments from the audience. I'd also like to make clear that in addition to these 4 experts, there are about 25 regional and you know, other experts sitting around the room. So we may, you know, if a question can't be answered by one of us, the 4 of us can say, like, hey, we know that so-and-so knows how to answer that. I think we have a microphone. Justine, are you going to man the microphones? Yep. So please raise your hand if you have a question or comment.
Hello, Ted Hooley with International Medical Corps. Thanks so much for the presentation. Very interesting. I wanted to just solicit some further comments on the communication part of the presentation. And I think you brought up some really good points about this militaristic way and these scare tactics, which I hadn't thought much of before. But I wanted to tie that also to the original mistrust between, and you mentioned trust building at the end of at the end of the talk, and how markedly at the beginning of the crisis, a lot of the conversation was trying to convince people that Ebola was something for real. You know, you'd see the signs painted on the streets of Monrovia, Ebola is real, let's fight this together. And I'm wondering, and would like to get your viewpoints on this, was once the epidemic hit, was it already too late to really establish that trust building, that two-way communication, if in the first place there was really no trust and any real desire, or not necessarily desire, but ability for, at the local level, to communicate with the national level? Does this process, is this something we can learn from going forward, saying this is a very basic element of fighting epidemics in the future, but in the moment, was it already kind of, how would that have worked during the actual epidemic?
Yeah, I mean, I would gladly solicit help from colleagues in answering this.
We have this kind of little mic.
Okay. Do I just talk here? Hello? Hello? First, though, I appreciate your question. Thanks. I am not completely against some of the militaristic uses, of getting the conflict. It's particularly great. I mean, it's understandable to see how it happened, particularly in Liberia and Sierra Leone, given their recent history of conflict. And that imagery is very good at, drawing people to, supply chains. Let's do something. Let's take it seriously. So there are advantages to it. But I did want to point out there are disadvantages too, particularly what we saw in Koidu 2 weeks ago. As far as the trust building and sort of engagement, no, it's never too late to engage with the community. And I should say, my discipline, we have often been, the people who advocate slow learning and, 13 months of, field work. No, that's not what I'm talking about. This can be done, engagement, trust building. This can be identifying local groups. This can be done in, a couple hours. There are rapid, assessments and rapid ways of doing this. So better to invest, 2 to 3 hours, maybe an afternoon, and then construct very effective messages and learn a lot from those people that construct messages that are very effective than what we've seen here, which was, up until August, fear, 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 call us. That in itself was kind of problematic, right? So ultimately, it's a much more efficient way of going about this. So can trust be built? Yeah, absolutely. I think that's what collaboration and communication is all about. Does anybody else want to add to that?
Yeah, and I want to invite not just questions, but members of our group who want to comment in response to questions, right? Justine? How about Mark?
I'm going to toss it back to you, Doug, because I know you have a lot to say about it. I'm just tossing you the ball here. And that is, you might want to talk a little bit about not so much the message, but the person conveying the message being crucial to this gentleman's question.
I'm sorry, I don't understand.
The person conveying the message and not just the message being important, identifying people who are already trusted to convey the message.
Yeah, right. So to identify those key people in the community, right? Who are these trusted? That's why, we were talking about religious leaders, society leaders. It's the same people that we work with, right, on a daily basis when we go and do work in West Africa. There are easy to identify social groups that would be great to work with.
Yeah, hi, my name is Claudia Vondrasek. I'm with Johns Hopkins Center for Communication Programs. This has been a really interesting panel, and I'm really glad that this was open to the public. My comment is that I think in response to Mike's comment, the border between for Côte d'Ivoire was just opened on October 20th. So I think any minute now we're probably going to see cases declared in Western Côte d'Ivoire. And I think what's particularly disturbing is that Liberians were blamed for a lot of the violence over the last 10 years. And as the Liberians and Guineans come across to participate in the cocoa harvest that also starts now, MSF actually did a study already in the end of September and identified that, Guineans and Liberians are already feeling that stigma. And I think that's going to be a real hard issue for the Ivorian government and partners to deal with, that we're not doing a lot of finger pointing, but rather, using those community responses to be able to work together and be able to protect communities.
Over here? Okay.
Yeah, my name is Maria Elena Figueroa. I'm also from the Center for Communication Programs at Johns Hopkins. I think this is a great panel. It has been very useful to get information from you guys. We're working in Liberia, and some of the information that we have been using to develop strategies of communication has come from some of you. I can recognize some of the names. And this is just a call to continue to coordinate and collaborate. We have a website that is called the Ebola Communication Network. We just came, actually, several of us that are here came from a meeting coordinating everybody. It's work, from different organizations. And So that there is a group also in Liberia. I'm sure there are other groups in the other countries, but at least in Liberia, there is a community mobilization group that has also a monitoring and evaluation group that we are supporting. And through that group, a lot of data and research is being shared and designed, and it's continuing to be, produced to continue to just inform strategies, because as you say, things are changing constantly. So this is just an invitation to link to that website, and as you guys develop new research, if you can coordinate with us also, because there's just limited resources, and there is need for more data. So if we can coordinate to continue to go deeper in issues that come up, they are getting ready to launch a survey, a national survey now. So I'm sure that there are going to be more questions and answers after that survey data comes out, so that, if there is resources like yours available, there can be a good opportunity for going deeper in exploring issues that can help really curb this and bring it down.
That's great. Thank you. And definitely one of the things that arose throughout our 2 days was the difficulties of collaboration. We know there are a lot of networks and groups and advisory commissions popping up, and we want to avoid duplication of efforts. And Sharon's already done a lot of great work on that on our behalf. Yeah.
Hi, I'm Kristen Post. I'm with the Center for Advanced Operational Cultural Learning with the Marine Corps. The question I actually have has to do with Facebook and their recent launch of a campaign. And supposedly the money is going not to MSF of the organizations that were listed. And I didn't know if you had any insight of whether that's to do with their historic rejection of outside influence, and they're wanting to seem neutral. But above that, I know this doesn't really apply to anything anybody specifically said, but obviously there's problems with too little money, and I imagine there's problems with too much money. And I was just interested in whether or not that's an unspoken concern or thing that you're watching as you talk about health systems and where support can go, or if that needs to be, especially now that there might be an influx, not only from Facebook, but from just the general world paying more attention to this issue. The associated problems with the too many funds going too many places.
I feel like all of us could answer that. How do we know who to answer? I mean, certainly people on the ground are concerned about where the money is going and the money flows. And so I think we even identified that as a potential research agenda for us, is engaging with local NGOs that have already been doing that kind of accountability, transparency work on the ground, as well as people who are looking at that here. And it has a long tradition, that, like we talked about, that led into the conflicts in the region, that same kind of level of concern about where is this money going. So that's definitely a risk factor, I think. Sharon? Or?
I'll just add to that, something to take into account with the money issue is that the Liberian health sector has been supported by the The Liberian health sector has been supported by the international community for at least the last 11 years to the tune of about $120 to $180 million a year, right? Now, cleaning up this Ebola mess, frankly, is going to cost many, 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 many billions of dollars, right? Which are already being expended. In addition to the sort of direct consequences of a massive saturation of money in the context of a crisis, which of course is going to lead to resource competition issues, we need to sit down and we really need to think about whether or not we're spending our money wisely by underinvesting in health systems on an annual basis and then having to overspend substantially to the tune of many orders of magnitude to address singular incidences like these.
We have 9 more minutes. Other questions or comments? Back in the back there.
Hi, my name's Marilyn Merritt, and I've done some work in the past in West Africa. One thing that occurs to me, which hasn't been specifically mentioned, is just you talk about collaboration, and then you've talked about the issue of trust with the community. But one of the things that I remember noting out in the field is that if you get two donors or two funding groups together and they want to talk about their data, frequently each group will want to go and collect their own data because the issue of trusting other people's data comes to the fore. So I'm wondering if you've thought about that or ways of proposing protocols, etc. I think it continues to be an issue.
Do you want to start?
Yeah, perhaps I should. We've been talking about data at length. Actually, and one of the things that I was trying to get at was not only do institutions not trust each other's data, they also don't trust sending it out when it may reflect unfavorably on the work that they're doing, or if the quality of the data might not be up to par for drawing certain kinds of conclusions. There's also a lot of concern about the ethical considerations about collecting data and about sharing that information. We have experienced a great deal of what do you call it, opacity, non-transparency about data, and access to data has been hasn't been forthcoming for people who are actually trying to model the epidemic and project, people who are trying to understand even the gender breakdown. I've had lots of people calling me saying, of course women are most affected. And I said, actually, the only real data we have are this last New England Journal of Medicine article that says it's a 50-50 split. What is fascinating is some of the regions in Liberia have very uneven sex distribution, gender distribution, and so looking at 50-50 in certain regions may not tell us much. We have a lot of cumulative data. I mean, I think I'm going off of track a little bit. We have a lot of cumulative data that don't explain how patterns of transmission might have been changing over time. But this gets at a larger, I think, issue about institutions and their cultures of transparency, accountability, and of extraction of data, information that they then transform into data that we've certainly been talking about.
Good. Anyone else? Well, if not, I'd like to take Chair's prerogative and give us a little break to stand up and maybe go to the bathroom, get some water, get some coffee, but come back in 5 minutes and we'll have the second panel.